The conduction system of the heart, this is a great kind of picture to follow along the next slide, but it consists of our electrical spaces, like our electrical activity spaces of the heart. We have the sinoatrial node or the SA node. This would be the pacemaker of the heart. It's in the right atrium. It's near the roof at the superior vena cava opening from an anatomical perspective. It's what initiates our impulse between 60 to 100 beats per minute that then spreads throughout the atria, spreads from Bachman's bundle to the left atrium. So that's how they kind of share that atrial impulse. Then it reaches the AV node, which is the atrioventricular node, which is going to delay conduction just a tiny little bit to allow for a separation between the atria and the ventricles. This is also, though, in the right atrium. It's on the interatrial septum. It's by the tricuspid valve and it's by the coronary sinus. And it's the only bridge between the atria and the ventricles. The fibrous skeleton of the heart is going to insulate against this otherwise. So if this is injured, the atria and ventricles will not communicate well. From there, it reaches the bundle of His or the AV bundle. This is how it's able to travel through the fibrous skeleton into the interventricular septum. And it separates into a right and a left bundle branch, RBB or LBB. The right bundle branch is in the right ventricle, the left bundle branch in the left ventricle, as well as anterior and posterior fascicles. And then from there, it will reach the Purkinje fibers. The Purkinje fibers are kind of allow for rapid conduction through the heart muscle um, from the apex to the base and direction, and it produces a coordinated ventricular contraction. The apex actually contracts first and pushes blood up and towards the ejection points of the heart. The septomarginal trabeculae is also another moderator band, and this connects or carries the right bundle branch across the right ventricle cavity, which is just a shortcut for conduction. If we only had the SA node working with no influence from any other parts of our autonomic nervous system, the heart would beat between 60 and 100 beats per minute. The AV node slower, 40 to 60, and Purkinje or ventricles on their own, not compatible with life because 20 to 40 beats per minute is just not fast enough. And these are the structures we're talking about. I mentioned a couple times this fibrous skeleton of the heart, and this is what it looks like here. So we might not think of the heart as having fibers or a skeleton or bones, but it doesn't have bones, but it has this fibrous skeleton. And muscle fibers of the heart are anchored to the skeleton. There's four rings, and they surround the four orifices of the four valves. So these are the kind of, we can see the rings here. And there's a light right and left fibrous trigone that connects the ring. So this is the left fibrous trigone. And I don't know if we have the right. Yep, we have the right fibrous trigone here. They're connecting these rings together. And again, the goal is to keep the valve orifices open so they don't collapse on themselves so blood can flow through. They also provide heart muscle attachment and they electrically insulate between the atria and the ventricles. Now, there are also some interesting kind of collateral blood channels that can exist. There are these vascular anastomoses. We could think of them as arterial or venous in nature. Arterial anastomoses are alternate pathways or collateral channels to ensure continuous blood flow. They're common in joints, the abdominal organs, brain, and the heart to make sure blood is flowing at all times. They typically aren't seen in the retina, kidneys, or spleen. We also have arteriovenous anastomoses. These are AV shunts between the arterial and venous blood, allowing them to bypass the capillary bed. We often call these meta-arterial thoroughfare channels. We have venous anastomoses, which are very abundant, so occlusion of any of these rarely is going to block any venous flow. And then varicose veins would be a pathology where we have an incompetent venous valve. So there's pooling of blood and vessel kind of distension or expansion. This is our whole kind of arterial venous system. And when we come back, we're going to get into specific blood that supplies the heart.